Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
I'm Dr. John Langell, President of Northeast Ohio Medical University, and it is my pleasure to welcome you to VITALS. VITALS is an open format to discuss the most pressing issues that we face in healthcare today, and to hear from the leaders in our community that are using the tools of VITALS to transform healthcare for all of us. VITALS stands for Value, Innovation, Technology, Advocacy, Leadership, and Service. And we are excited today to be able to welcome Dr. Thomas Vo, the CEO of Nutex Health. Dr. Vo brings more than 25 years of experience in the business of medicine. Over the course of his career, he has been instrumental in the startup and management of over 30 specialty hospitals and emergency centers throughout the United States. He has been recognized by his contemporaries as one of the pioneers and leaders in the field. And in 2020, Dr. Vo received the prestigious Ernst & Young Entrepreneur of the Year Award, where he went on to become the national finalist. As a NeoMed alumnus and transformational leader, he graduated from Kent State in 1992 and Northeast Ohio Medical University's College of Medicine in 1996. He completed his emergency residency at William Beaumont Hospital in Royal Oaks, Michigan. And in 2004, he also completed an MBA from Rice University to learn more about the business side of medicine. We are excited to hear from Dr. Vo today. Dr. Vo, the floor is yours.
Thank you, Dr. Langell. And thank you, NeoMed, for inviting me to this very, very important forum where we could all discuss the many issues that we face in healthcare. And we're certainly involved with a lot of those issues. And but more importantly, we're trying to solve it. And we're trying to make it a better world and trying to be disruptive to medicine, to the status quo, as you can say. So when Dr. Langell and Roderick invited me to talk with NeoMed, I was trying to think, okay, what can I impart on current students that are sitting there? Because I was in your shoes or in your chair 25 years ago, doing the exact same thing that you're doing, studying the hardcore sciences, the biology, the microbiology, embryology, so on and so forth. Not knowing that, not ever imagining that I would be embarking on a sort of like a administrative entrepreneurship role. Because at that time, my 100% focus was to be the best physician I can be, which is exactly what everybody should be doing right now, is studying the hardcore sciences, studying how to be the best clinician, physician as you can. So my role here really is to give you a slightly alternative model, give you the good, the bad, the ugly of what it's like to be an entrepreneur, to run a company, a public company for that matter, and see whether or not you like it or not. I would venture to say that 95% of physicians who graduate stick with clinical medicine, which is, I think, where most of it should be, but the few that do venture out and do, something along the lines of entrepreneurship or running large organizations, I just want to show what it's like, and good and the bad and the ugly, like I said, because it's not all fun and games. There's a lot of glory to it. There's a lot of blood and guts, literally, unfortunately. with running companies. It's not for the faint of heart, unfortunately. There's a lot of risk involved. So let me give you a slight background on where I came from and where we are now and where we're going in the future. So I did graduate from Kent State back in '92 and NeoMed in '96. Back then, Roostown was, I believe, much smaller than where we are now. I had the pleasure of visiting Dr. Lancho maybe a couple of years ago and found out that NeoMed has not only pretty much doubled in size, but now they have a clinic. Now, I think there's talk of bringing an urgent care in. And so, you know, NeoMed and Rootstown has gone places and obviously have grown quite a bit since I've been there, which is fantastic. And I look forward to come back many more times to visit with Dr. Lancho on the team. After I finished my finished medical school, went on to do my residency at William Bowman Hospital, where I've completed my residency in '99. And then from there, since my wife, she's a class of '97, I waited for her to finish her internal medicine residency at Beaumont also, and we moved down to Texas because that's where she's from. When we went down to Texas, I took a job at Methodist Hospital, probably the largest hospital in town, and worked as a clinical physician for at least probably 10 years. At that time, I learned the skills of medicine, learned how to be the best doctor as I can, and basically set on the pathway that you know, I was landing on when I was sitting in that seat where you are now, and be the best, try to be the best clinician and physician as I can. It was during my work there that I saw, you know, of course, there was a lot of issues, but from my standpoint as an ER physician at a very busy downtown hospital, I saw that there was a big issue. The big issue for me at that time was, and I don't know if you guys know Houston or not, Houston is like the size of Connecticut. It's humongous. And this was back around 2010 or so. What I found was that patients from all over Houston drove to the medical center, which is the largest medical center in the world, fight all the traffic, have to park in a garage, pay at that time $10, it's $20 now for parking, go down the elevator and go to the ER and wait 5 hours for me to see them. And so the thought came to my mind was, there's got to be a more efficient way for those patients to not have to drive all that way, not have to pay that $10 or $15 to park and wait 5 or 6 hours. So at that time was when we sort of like, you know, but we opened our first sort of like emergency room in Houston. And from there, we basically, it just grew from there, and we expanded around Houston. And then we expanded around Texas. And then from there, we expanded nationally. So now we basically converted our emergency room concept to more of a micro hospitals. And so now we have 22 locations in 8 states. And so what is a micro hospital, you may ask? So a micro hospital basically is a small hospital. And I'm sure for those of you guys that have done clinicals before, I'm sure you've seen, say, Akron General or St. Thomas, which I don't know if St. Thomas is there anymore. But these are big hospitals. These are like 200 bed hospitals. Our hospital are more closer to 4 beds. And the reason that works is because we only focus on maybe 2 or 3 core things. We focus on the emergency room. We focus on inpatient for the selected patient. And then everything else we refer out. So like, for example, we do not have an operating room, although some hospitals do. But for the most part, we don't do surgeries there. For the most part, we don't do ICU patients. And so if there's any patient that requires surgery or an ICU, then we would transfer it out to, say, an Akron General or, you know, somebody along that line. And so what we find is that there's a big demand for our service around the country. And this is where, you know, this is where we sort of like disrupt medicine, because, you know, our position is sort of like above an urgent care, but below a big hospital, like an Akron General. So that we do see a lot of volume and there's a lot of demand for our services. And so this is where, you know, sort of like number one, our disruption comes in the sense that we do something that is no one else has done before. We do something that is provide a valuable values to the public, and we provide a backdrop as well as a safety net for the community, so that they can come and see us if they have an emergency. And then in the introduction video, you saw that there's a humongous need for primary care doctors, and we see it. Unfortunately, there's not enough doctors, primary care doctors, to take care of these patients. And so unfortunately, a lot of these people come to us simply because they can't go anywhere else. That is the unfortunate problem. And so, I see us as filling a need, but not only that, unfortunately, because of the dynamics of the system, we become a very necessary need for a lot of patients. Obviously, it's not as cost effective to use emergency room, but if you don't have any other options, then we're the safety net. Having said that, we basically provide care to pretty much everybody 24/7, and we don't turn anybody away. And so in reality, we're basically complement the bigger hospitals, so that we decompress the ER, but yet if there's a patient that needs to be transferred, we transfer to their hospital respectively. So currently we have 22 locations, but we're basically have 20 more locations that are coming up that we're building right now that are under construction. And the reason for that is because of the humongous need for our services. And in fact, most of the time when we go out there, local doctors call us up and ask if we could help them build a hospital so that they could invest with us and be sort of like an investor in a hospital and be able to run their hospital. And so our model is unique in the sense that we're physician-led. And we'll go over, in the future, later on about, why that's important. But we also give everybody skin in the game. And by that, I mean, we also give physicians an ownership in the hospital so that they can participate in the care of the hospital, as well as providing the best patient care possible. And why do we do that? Well, we found over the years that obviously it's not only cool and exciting to open up business, but it's more important that we make the business sustainable as well as profitable, because you cannot open a business without being profitable and sustainable, because otherwise you're just losing money and you just have to shut down. And so the way that we found ourselves to be sustainable is that we focus on one thing, and that's patient care. We focus everything around the patient care. And so how do you do that? Well, you need to make sure that the people who treat the patients are happy, because like it or not, we're in a people business. And dealing with people, you have to make sure that they're happy, and you have to have the skill set to do it. But more importantly, you have to have the alignment as well as incentive for the providers to do that. Because what we don't want is for our physicians or nurses or techs to be angry, right? Because when you have an angry doctor or nurse, you're gonna have an angry patient. And unfortunately, with the current climate and a lot of the bigger hospital systems where there's long waits, lack of staffing, unfortunately, there are angry providers, and that sometimes does not lead to the best optimum healthcare. And so that's where we come in, because we incentivize our doctors by making them an owner in our company, so that we all could treat the patients better and make sure that the patient is taken care of. Well, how else do you get to incentivize everybody? And so, the other way to do it is to, not just, I think I have a question for Dr. Lancho.
Oh, you can wait. That's for after your talk. I just had a question for you.
Oh, I'm sorry. I'm sorry, Dr. Lancho. Okay, yes, I have 3 more minutes. So, yes, let me finish my thought here. So, so the thought is well, how do you incentivize physicians and nurses so that they become just as passionate about patient care and provide the best quality of care as anyone should. And so that led us to become a public company. And the reason we became public is to provide that currency so that everybody could have skin in the game, so that everybody could basically have that sort of like ownership mentality, and then so they could take care of the patient, go the extra mile to take care of the patient. So that's basically sort of like the idea. And obviously, it's a big operation. We have over probably 1,500 employees, over 250 physicians that work for us. And so, from a business standpoint, there's a lot of work that's involved to provide the best patient care possible. There's a lot of sort of like personalities that you need to deal with as a business owner or as a leader. And there's a lot of pitfalls also. And so the trick is, how do you incentivize all the physicians and nurses to provide the best care? How do you do it so that everybody is excited and goes to the shift every day, wanting to take better care of the patient, so that you have the best outcome for the whole organization as a whole. And so the other thing that I wanted to bring up is that the company that we merged with when we became public is a population health company. They deal with primary care physicians, with IPAs and MSOs, and I'll be happy to explain that later if there is time to discuss it. But in essence, IPAs and MSOs are designed to address one of the issues that was in the video, and that is the cost of medical care. And so the idea is that if you basically get all the primary care doctors together and incentivize them to treat patients better, and once again, it goes back to patient care, and give efficient care, then you could minimize the cost to insurance company and to society as a whole. And so we basically incorporated that into our company, and now we are merging the population health side with the micro hospital side, so that we're making it something that, as far as I know, no one else is doing. So that is something that we're doing now. We believe it's very disruptive. Like I mentioned, we have 250 doctors, and we need every single one of them to be leaders in their respective hospital and IPA models, so that we all could function on the same page. And so I think I have 1 more minute left, but this is sort of like an overview of what we're doing. And like I said, for those of you who are sitting there, in your biology class or microbiology class, some of this may or may not seem relevant, but you never know. I mean, in the future, there may be a few of you guys that do take this route. And, hopefully I could be maybe either a role model and inspiration for doing that or not. But this is just something that is available, because once you finish with your career, either it's a PharmD, dentist, physician, what have you, you do have a lot of career choices. And like I said, probably 95% of us stay with clinical medicine, but there are some other options out there should any one of you guys want to explore that option. So I think my minute is up, and so we could start the questions. So I'll introduce back to Monica.
Dr. Vo, thank you so much. And thank you to all of our participants. We've got about 47 of you in here, and we already have a question from Vivian. She wants to know, what are the parameters or the ICD codes for admission to your micro hospitals? Yeah, so we basically, since remember, we don't have an ICU, we don't have an operating room. We admit mainly medical patients, and so basically anything that could be taken care of by the internist, we could take care of. So we're talking, like pneumonias, light pneumonia, mild CHF, maybe mild urine sepsis, kidney stones as an example, dehydration, vomiting, diarrhea as an example. And then obviously COVID. During COVID, we saw tons of COVID patients, and a lot of them may just need 1 to 2 days of oxygen and some steroids and some IV antivirals, and they go home, right? The problem is when you go to a much bigger hospital system, they may not have room or time to take care of some of these, not so severe diagnosis, and so that's where we come in. And then anything above that, we transfer to the bigger hospital system. And the bigger hospital system love us because number one, we sort of like keep the patients in that area, and number two, they get a referral from us for the sicker patients, which is what they want.
Dr. Langell actually put in a couple of questions. I'll get to those in a second. I just wanted to remind our participants that feel free to put any questions for Dr. Vo into the Q&A section, and I will be happy to ask them for you. Dr. Langell's question, the impact you are having in your current role seems more as a business leader rather than a clinician. What stimulated your passion to pursue the business of medicine?
Yeah, no, great question. And so, yes, right now, my role is more of a business leader, although, like I mentioned, we have probably over 250 clinicians that work underneath our company. And so my role is to lead those clinicians. But you know, I think what stimulated was that I recognized that there was a need for physician leaders to lead medicine, because I think it's important for physicians to take a more active role in medicine, because we're there, we're in the front line, we're in the pits, we're the pit doctors, so to speak. We see what the ministers don't see. We're there at 2 a.m., take care of patients. There's a lot of stuff that happens at 2 a.m. that if you're not involved in that, you don't know about it. And so, it takes somebody like that to know what the issues are so that you can fix it. And so I think that's very important, to have physicians who, are more aware of just more of the surrounding, more so than just being clinician. And trust me, don't get me wrong, being a clinician is a very, very noble and very great profession. But my only comment is that occasionally, even if you just want to stay in a clinician, you should, probably learn some additional skills that could augment, what you do as a clinician. And so the second question is, do you believe the medical school as a whole prepare future physicians to lead in the business of care? So the answer is, so when I went to medical school back in from 92 to 96, the answer was no. And the reason I say that is because at that time, I did not take a single accounting class. I did not take a single finance class. I did not take a single leadership class. There were no speakers like myself and that Dr. Langell put together to sort of like come and talk about, all the possibilities back then. Not to say that, they didn't believe in the importance back then, but back then that was just not on the radar, unfortunately. And so I think what Dr. Langell is doing at the school is, in my opinion, very revolutionary, because what he's doing is introducing this concept of physicians taking charge, physician being the leader in future communities, future healthcare networks, future endeavor. And so I think, and I do think that the future of leadership will be physician related. And so I think it's important that all of us, including the current physicians here, at least learn some business skills. And by that, I mean, learn some accounting, learn some finance, learn some leadership skills, and learn some people skills. Because like I mentioned before, we're a people business. And whether you like it or not, you can have to be a leader in some capacity or another. So for example, when you become a physician, you're already a leader by the virtue of the fact that you have the title. And even if you don't lead a big organization, you can lead a small team of nurses and techs and, maybe junior doctors and residents. And so by that virtue alone, you're already a leader, right? And so you just need to get used to being a leader, whether you like it or not. Unfortunately, that's just being part of the game. And by being a leader, you basically, have to learn how to, dress appropriately, act appropriately. When you come into either an office or building or, wherever, as a leader, everybody's eyes are going to be on you. So you have, so every single reaction, every single body posture, every single, body language, every single tone of your voice, the way you dress, everything, people are going to look at that. And so, just have to think about, that kind of stuff. These are all what I call soft skills, but it's very important skills. Unlike the hard skills, like the science and the, physics and so on. Those are obviously, you need those skills. But the soft skill of leadership is what I think that, and you don't have to do it now. I mean, when I was there, I didn't care how I dress, and that's okay. But as long as you sort of like have a vision in your head that eventually you're going to need to care about the way you dress, the way you act in public, the way that, you behave, because like it or not, once you have that MD, PharmD, DDS behind your name, you're automatically going to be a leader. and you're automatically going to be a high member of your society, wherever that is.
The second part of Dr. Langel's question, and we'll take medical schools as a whole, do you think they prepare future physicians to lead in the business elements of care? And if not, what are the key foundational elements that medical schools should be taught or should be teaching?
Yeah, I mean, I'm not as up to date as what other schools are teaching, but just based on my historical perspective, I don't think medical school as a whole are doing enough to teach physicians sort of like the art of leadership, the art of being a future leader to lead healthcare. And so I think, and this is what I learned from my MBA class. And honestly, when I did my MBA, it was a great eye-opening. Not that I learned a lot, but there's like 3 or 4 things I learned in my MBA class that I wish could have been taught. Number one is numbers. Learn how to look at numbers, because when you open your own office, when you open your own clinic, no matter what you do, you have to be comfortable with the balance sheet and the financials, right? Because that's sort of like the basis of how successful you can be. Number one. Number two is, like accounting, finance, accounting, and, need to learn. You don't have to be an accountant. You just need to look at numbers and say, hey, we're profitable, we're not profitable. Here's are some issues that we could make it more profitable, as an example. Number two, like I mentioned, is leadership skill. And obviously there are a lot of different types of leaders, right? Dr. Langell is certainly a leader. But he's not a general in a battle, right? In a war battle, the general is a different type of leader, right? President Biden is a different kind of leader, right? And some of us lead by example, some of us lead by inspiration, right? And some of us just lead by just actions. And so, and once again, you don't have to be an expert on leadership. You don't have to be an expert on accounting or finance. You just need to sort of like develop a mindset that you may need to learn that as you progress with your education. But those are, in my opinion, are the foundations of what it takes to be a leader. It's just, learn how to deal with people. And like I said, once again, people is the foundation of what we do. And so you have to be able to deal with people, either as a patient, colleague, employee, boss, whatever it is. You have to learn how to deal with people. And so, if you know how to deal with people, and some of us are born with it, some of us are taught, but unfortunately, with what we do, dealing with people is everything. And so you have to learn that skill.
Dr. Vo, Matthew wants to know, where do you see Nutex in 5 or 10 years?
So right now, we've basically just became a public company 6 months ago. We've put out 1 quarter of financials. And unfortunately, the first quarter compared to last year was not very good. And the reason was that we had a big legislative law that sort of like impacted our revenue by about 30% this year. And so our revenue went down 30%. And so when you compare us to last year, before we became public, we were a much more profitable company back then. But having said that, basically, we still believe in the business. We have a very strong business model. Right now, we have 20 locations. We have 20 more locations that we're going to open up. And once again, because of the way that we basically incentivize everybody, all the doctors, all the nurses believe in the company, and foundationally, we're very strong. And so my answer to that is that in 10 years or 5 or 10 years, we hope to be at 100 locations. And each of those locations will have an IPA wraparound, so that we could have a group of primary care doctors around each of the hospital, so that we could use it as a way to save on costs. Because as you know, hospital cost is probably one of the more expensive costs of medicine, right? And so if we could own that piece of it, as well as control the referral network from the primary care doctors and control the cost of the hospital, I think that's where our value comes in. And so that's where the innovation and the value base comes in, is because of the sort of like synergy between the PCPs, primary care doctors, as well as a hospital. And that's something that, as far as I know, no one else is doing. Obviously, it's never easy to get anything off the ground, but we're definitely gonna try our best. And obviously, with the stock and the incentivization of the doctors and the nurses, we have the foundation to make it successful simply because everybody's rowing in the same direction.
How many states is Nutex in? Just Texas or no?
I don't know. We're in 8 states now. We're in 8 states. We're trying to open in Columbus, Ohio, actually, in Cincinnati. And so by next year, we should be in, I think, 14 states. And it's on our website, is public information. We're going into Wisconsin. We're going into Florida. We're going into Idaho. We have an IPA presence in California. So we're doing, some urgent cares in California. So we're expanding quite rapidly, and being a public company definitely helps with getting funding for that. And once again, public company, it's basically it's a currency. And so, even if the nurses or techs aren't invested in directly in the hospital, they will have investment in the stock, which will then basically, once again, get everybody to roll in the same direction, so that when the ocean rises, all the boats rise, right? That's what you want. And so that's basically what we're trying to do. So we try to align with everybody so that everybody's got the same alignment.
Joseph wants to know, are you concerned about evidence that suggests when physicians own hospitals, they're incentivized to direct patients to the facilities that they own and perhaps initiate care strategies that optimize revenue generation because profit becomes the primary motivation rather than optimal health care?
That's a great question. The answer is, that may happen. Yeah, that may happen, obviously. But the biggest thing for us is that we value patient care over everything else. And that's basically, as physicians, we value patient care. And so whether or not, you treat patient better or worse by, having a patient coming to a hospital that is basically has ownership by physician, that's debatable. But the point is that the structure that we set up basically aligns itself so that patient care is getting taken care of with the best patient care possible. And so, I don't foresee that any physician will line their pockets more by doing that, simply because if all of us believe in patient care and use patient care as sort of the core strategy and the core belief and the core mantra that we want to develop, then that issue goes out the window, because ultimately it's a patient care that is the main core. And so, yeah, I do not believe that profit over matters, because if you provide patient care, the profit will automatically come. So it's the opposite way of looking at it.
I just want to encourage our participants, if you have any questions for Dr. Vo, please put them in the Q&A section, and I'm happy to ask them. Fayez wants to know, do you have any educational internship programs for students to learn more of the business side of medicine in your micro hospitals?
Yeah, no, we always have, not official programs. But at any of our hospitals, if anybody wants to come and rotate through there, we'd love to, entertain pretty much any and all, because, it's just a way of giving back and a way of educating, the public. And obviously, if there's a, any interest students that wants to do it, for sure we do it. But we don't have anything official, though. We don't have anything sort of like a program or an internship program or anything along that line yet at this point. We may institute that in the future, but for now, it's just, depending on when the needs are. And in fact, we do have, some relationship with some nursing schools where they rotate, nursing students through the hospital, as an example, or, tech programs. And occasionally, medical students rotate and shadow one of our physicians, but it's sort of like more of a one-off, more so than anything more formal at this point.
Jean wants to know, micro hospitals seem to move against the trend of hospital mergers and systems getting larger and larger. How are micro hospitals received in that landscape?
Yeah, no, exactly right. I mean, and then that's what the disruption that we're talking about, right? Because right now the trend is for merger and acquisition for bigger hospital system to take over smaller hospital systems, right? That's the trend. And so you're exactly right. I mean, that's where our disruption is. That's where our value base and innovation is. So, and as you know, most bigger hospital systems are very bureaucratically run, lots of red tape. And that's why a lot of us move away from the big hospitals. I mean, I always grew up in a big hospital system. You know, I trained at Beaumont Hospital, you know, probably the largest hospital system in Michigan for sure. I don't know if it's the largest in the Midwest, but it's very large, very bureaucratic. You can't get any decisions done. If two doctors want to get something done, there's absolutely no way they could get it done, right? And then the hospital that I worked at in Houston's Methodist Hospital system is the biggest hospital system in Houston. Very good system, but once again, anytime you get into a big system like that, it's very bureaucratic. You know, our voice, physician's voice, become very minuscule, very small. And so, you know, and I think that's the frustration part. That's why so many doctors reach out to us to want to participate with us, so that they could have a say in how they run a hospital, who they hire, what policies, you know, they do. And so, no, you're correct. I mean, we're definitely going against the grain at this point. And the reason is just the demand that physicians have, because a lot of us, you know, once we work in the biggest hospital system, we've seen it all, right? And so, you know, a lot of us have sort of like reached a ceiling of where we can't move up anymore, and whatever we say or do, you know, may not matter. And so this is where sort of like physicians sort of like take back that decision making in our own hands, so that we could make those decisions and provide the best patient care, right? Because once again, it's all about patient care. It's all about having the time to sit down with your patient and you know, give them, you know, your best, and go the extra mile for the patient. In the big hospital system setting, you may or may not have that time, because you're so busy with meeting all the metrics, meeting the expectations of VPs this, VPs that, right? I mean, nothing against big hospital system, but they're just big and they're built like that. And so for them to go from big to small is very, very hard. And so that's what we basically going from zero to a small hospital, and take out all the layers, so that really it's just physicians, patients, and providing the best care. And once again, we 100% believe that if you provide the best care to the patient, then everything will follow, right? As opposed to the other question of, you know, maximizing the profit in order to get good patient care, we're the complete opposite. Does that make sense?
One of the things we're seeing in Greater Cleveland is that a number of the big hospital systems are actually closing their smaller hospital systems, leaving somewhat what the residents would refer to as a health desert.
Right.
Are you going to see more and more Nutex type companies moving into these communities? Is it beneficial, and how does it relate to population health and value-based healthcare?
No, absolutely. And that's the problem, is that, you know, I was talking about the good, bad, and the ugly. So this is the ugly side of hospital medicine, is that most hospitals are losing money left and right. I think Dr. Lancho sent me some numbers that Cleveland Clinic, the great Cleveland Clinic, is, you know, last year lost $1 billion. That's a significant amount of money. And so, you know, and so the question is, well, how do you reverse that? How do you, you know, create a better model where hospitals aren't losing money, but yet provide value to society, right? And so that's, I think that's where the micro hospital comes in, because we don't have that overhead. We don't have all the, you know, layers of administrations, you know, and so our costs are lean, we're small. And like I said, it's just physicians and the patient, and that's it. And so number one, so for the desert, yes, that's where we would target to go in. Now, obviously, you know, we're a private business. I mean, we're a public company, but we're a private business in the sense that we won't get bail money from anybody. And so, you know, so as a good business, you need to be open in an area where you think you can be profitable. Not wildly profitable, but just profitable, just so you can pay the doctors, nurses, and, you know, pay the employees and so on and so forth. And so, you know, some of those deserts are hospitals that, you know, obviously fail to make a profit, right? And so the question to us is, okay, if Cleveland Clinic or University Hospital, if they fail at that location, what can we do to make it better? I mean, are we any smarter than they are? No, obviously we're not any smarter, but we do have a more efficient system where if a UH system failed, maybe we could buy that hospital and institute our model in it so that we could cut costs, improve patient care, and increase, you know, margin. Because once again, it's all about patient care. It could have been that the smaller hospital system shut down because patients didn't want to go there because they had horrible care, and so they had no patient, you know, no return visits. Whereas when we come in and institute the model of physician first, physician alignment, nursing alignment, best patient care, then maybe we could turn that around and create a valuable model for that community, right? We're not any smarter than the Cleveland Clinic or the university system or health system or anybody like that. We just have a slightly better alignment with everybody else. And then in terms of population health, yeah, I mean, if there's a way to create a group of primary care doctors and specialists around that hospital, so that we could all sort of like function in the same ecosystem, sort of like a Kaiser Permanente, except on a much smaller scale, right? Because Kaiser in California, they own except the fact that we won't own the insurance side, but the Kaiser basically controls their patient. They have their own primary care office, they have their own specialist office. They don't own urgent care, they don't own hospital, right? And they're all over California, Northern California, Southern California. But when they expand to other states, they found that it just didn't work as well because none of us are California, right? And so my point is that if you create a much smaller Kaiser, then it may work and it may provide that value add that Kaiser, failed to do. So going back to your original question of desert, yes, we would love to take a look at all those, and we're doing it now. We're looking at, some systems in, like, say, Indianapolis, where the big hospital system, shut down some of the smaller hospitals. Then we would just basically take over that smaller hospital with very little cost, and then start putting in our own physicians and using our own sort of like method and technology to run that hospital, provide patient care, and once again, doctors and nurses and patient, and that's it. And take away all the overhead, all the layers of what most big hospital systems have.
One of the drawbacks I would assume that many of these hospitals were dealing with was Medicaid and Medicare payments.
Right.
So, you talked a lot about going into a healthcare desert. Obviously, it has to be profitable. So what are the other factors taken into consideration when you choose a hospital or choose a location for a micro hospital? And for example, why did you choose Columbus and Cincinnati?
Yeah, no, great question. So no, it has to do with demographics and it has to do with volume. The reason for Columbus and Cincinnati, well, and we looked at Cleveland also, but Cleveland is very saturated. There's just not too many, deserts, as you can tell. But Columbus and Cincinnati, there are some quote deserts that we could open and make a difference. And so, one of the first criteria is there a need? Is there a need for our services in that community? Right now, Cleveland doesn't have a need, as far as I know. That could change, obviously. But in Columbus, like in the west side of Columbus, Dublin, I don't know if you know where that is, but northwest side of Columbus, and there may be a need because most of the hospitals are on the east side, right? And patients don't want to drive all the way to the west side to get care. And then Cincinnati, it's a little saturated downtown, but in some of the northern suburbs of Cincinnati, there may be, some desert. And so, we look for those criteria. And the reason we say with a, slightly bigger metropolitan area is that there's just more need and more volume, right? And then the other thing is that, we know for a fact that, like, for example, blue collar workers tend to use hospitals more simply because they have more injuries and they don't have their primary care physicians, they don't have relationship with physicians like, say, white collar workers, right? Because most of us here are physicians, and so white collar workers sort of like tend to have friends or buddies who are physicians, whereas blue collar workers may or may not have that privilege, right? As an example, and so their need for Medicare goes up. And so some of our busiest locations are, blue collar areas, not like, wealthy areas, not like, sexy areas, just, hardcore blue collar, working type, neighborhoods. And so some of those neighborhoods, are where we see the most volume of patients. And so you just have to sort of like identify areas where there's the most need and then try to solve that need. That's basically what we do. We see a need and we solve the need using our value, using our innovation, using our alignment, using our, sort of like, infrastructure.
So I'm familiar with both of those locations that you're referring to in Cincinnati and Columbus, and both of those areas are fairly wealthy, and pretty much most of the people in those areas have their own individual healthcare insurance. So how do you consider types of payers and insurance when choosing new sites? And also, how much charity care does Nutex give, and how many Medicaid patients do you see? Because that's actually, from my perspective, where the biggest need is.
Yeah, no, we see everybody that walks through the door. Because we're a hospital, we have a 24/7 emergency room, we follow HIPAA. And we see everybody walks through the door. And we do what's called medical screenings. And so, for example, if a patient does have insurance and they come in with a knife in the chest, we see the patient and we take care of the patient. And even if the patient doesn't pay in the future, it's okay, because we have to, take care of the patient and do what's best. On the other hand, if a patient comes in and let's just say it's a chronic, disease for, 6 months, and the ER physician determined that the patient doesn't have a life-threatening danger in the next, say, couple weeks, and that the patient could stay alive and follow with their primary care doctor or follow with some clinic, then we discharge the patient. So that's basically, sort of like our role to society, is that we see everybody. Now, the Medicare, Medicaid population, and I need to be very careful with the way I say this, is that there are slightly different medication in this, different population in the sense that for these populations, and once again, I need to be very careful in the way I word this, because not everybody's the same. But when you have government resources, care is free, right? And so what we find is that a lot of these subgroup of patients may not take the time to follow up with their clinics, right? But the other issue is that the number of clinics that does see Medicare and Medicaid are few and far in between. And so you really can't blame them for using the emergency room as their primary care physician, because they don't have any other options. So it's actually a combination of lack of resources on that side, as well as, no penalty for using the emergency room as a primary care doctor. And so, at every big hospital, like you said, lots of Medicare, lots of Medicaid, and it's a multi issue with either lack of resources to treat them on an outpatient setting, as well as lack of punitive damage if they come to the ER, right, for care, because it's free care, right? Whereas for people with insurance, there are co-pays, co-deductibles, and so if you really need to see, you have to pay a copay, right? There's a punitive, but for Medicare and Medicaid, there's this that doesn't exist right now, right? And so yeah, that's a problem. That's one of the problems that we're facing, and this could be one of the problems that hospitals are losing a lot of money simply because of that, massive volume of patients. Having said that, however, we also do see a large amount of patients who are not insured, right? And the funny thing is that a lot of these patients who are not insured doesn't mean that they don't have cash. So we see a lot of, quote, uninsured patients that comes in driving a Porsche or a Ferrari. And a lot of these guys are like business owners, small business owners. And the reason that they don't get health insurance is because, they're banking on the fact that if they just need to get seen care, once or twice a year, then instead of paying, $2,000-$3,000 a month in, their premium, they could just pay a couple thousand and get it done with. I mean, they make money doing that, right? Obviously, there is a catastrophic injury if something happens to them. But my point is that, and so that's the other thing, is that even if you do have insurance, the premium costs so high that even if you could afford it, you may not want to afford it, because you can put your money in other ways, like opening a new business, right? As evident by these, say business owners, bar owners, or whatever it is. So it's a very interesting dynamics. And the more we get out there, the more we see that pretty much everything that on that video that was a problem with healthcare, we're seeing it. And because we're in the front line, we're basically seeing every sort of like once again, good, bad, ugly of society. And I mean, our I don't know, we're there to fix the world, but we're just there to pretty much help get it better and maybe plug in some of the holes.
Another question from a participant: as you transition from ER physician to entrepreneur, were there any missteps or hurdles you encountered that you would counsel others to avoid?
Yeah, lots. I made lots of mistakes, unfortunately. So let's see, where do I begin? I mean, I could write a book on all the mistakes that I made, but I think the biggest thing to consider is that, number one, whether or not you like it. Number two, consider whether or not, you're willing to go the extra distance when there is adversity, because you're going to have adversity. I think something like 9 out of 10 new businesses fail. And that's true. I know for a fact that it fails. So it's not easy. And like, for example, now we just became public and insurers are cutting our reimbursement by a third, right? And as a public company, that's not good, because then, your stock tank because of that, right? That's an example. So we're sort of like going through that now as we speak, even though on a much, bigger scale. But the point though is that number one, you have to, like what you do, because it's much safer and much more secure to, work as a physician and just have a constant paycheck coming in. But if you do like being an entrepreneur, then, you just have to make sure that, you have, backup plans in case the business fails, number one. Number two is that you need to align yourself with the right people. Once again, it's all about the people. And if you align yourself with the wrong people, sometimes it takes years to untwine, right? But the problem is sometimes you don't know, right? And then, sometimes when, you get a business together and the business either does well or doesn't do well, the true character comes out, right? And so the point is that, if you do it, and I recommend you try to do it, if you can, if you have a passion to do it, but, you just have to choose the right people, find the right business that serves humanity and provides value to the public. And if you like the business, then, be prepared to, face adversity and don't give up. And so, so that's basically my advice is find a business or find something that is worthwhile to do, that serves a purpose, that creates value for the public. Once you find that, if that potentially can be a profitable business, then I will stick with it and find the right people to work with. And if you do that, then there's a decent chance that you may succeed. Either that or win the lottery. So that's the other way.
A lot of what you're saying, though, for physicians who may be going into general practice, this is something they would need to know anyway. If they
need to know
start.
anyways. That's correct. That's what I mean. Yeah, because when you open your own clinic, that is opening your own business. So you do need, to know accounting. You need to know financing. You need to know, loans, right? You need to hire the right people, because if you hire the wrong nurse or the wrong tech, I mean, that could set you back like 6 months, and you may not have cash flow to sustain 6 months worth of payments. So yeah, no, I mean, everything that I'm talking about, 100% could relate to what each of these physicians or pharmacists, when they get out in real life. And once again, you don't have to, you may be a first-year student, second-year student, you may be sitting there. I mean, you don't have to do it now, but, as a result of this, just think about, how to be a better leader, how to be a better, business owner, how to be, think about, when you get out, after residency. And if you do open your own clinic, think about, ways, to do that. And you should start now and just start write down stuff that, because it's going to come sooner rather than later. And so the sooner you can think about it, put it in the back of your mind, the better you be once that day comes.
Curious, does Nutex keep analytics on patient outcomes, and do you screen for social determinants of health?
No, we do. We basically we follow up with patients, pretty much every single patient. We follow up. One of the physicians calls the patient back, next couple of days to see how they do. 90% of our patients get seen and discharged, right? The other 10% gets admitted. That 10%, 5% gets admitted to our own hospital. The other 5% gets transferred out, roughly. So yeah, no, we have all kinds of analytics to, follow with patients, see how they do. I mean, what we do find is that, most patients are very happy with our care. And most patients overall, would come back. And when you look at like, how we get new patients, obviously, location is very important because people drive by you, right, and see you. But the second way the patients come is through referrals, right? And the reason the reason they come because of referral is because the quality of care that they get at our hospitals are high, and so they tend to tell other people to show up, right? And so we know that for a fact. And so we know that once patient gets a referral, they wouldn't do it unless they've had a very positive outcome, right? If they had a negative outcome, they wouldn't have referred that patient to you back. And so we have a very high referral rate. I know the social media is one of these sort of like soft, skill that you have to learn, but we get tons of positive reviews on social media, LinkedIn, and things like that. So all these come together to tell us that what we're doing, we think are working. Patients are happy. Patients have a good outcome because they tell other people, right? And then occasionally when we have a bad outcome, we basically fix the issue right away by either just tell the patient to come back or tell them to follow up or something along that line. But we have a methodology of figuring that out because we do call or email patients back after a couple of days.
Dr. Vo, thank you so much. I can tell by our participants that there must be a 1 o'clock class coming.
Okay.
So I'm going to hand it back over to Dr. Langell.
Thank you very much, Monica, for your expert moderation. Dr. Vo, thank you for sharing your story and the great work you're doing in a non-traditional area in medicine to address deficiencies in care.
Thank you. I hope I've been helpful to yourself, Dr. Langell, and to the university and all the students.
Yes, and we're proud to have you as a graduate from this institution. Thank you. And for everyone else, next month, we ask that you please come back and join us for VITALS on November 10th. At that time, we will have Dr. Forrest Faison, retired Vice Admiral and the former Surgeon General of the United States Navy. He will be joining us the day before our nation celebrates Veterans Day on November 11th, and will be a key speaker for us on NeoMed's Transformational Leaders Day. Until then, stay engaged, stay active, and be advocates for your patients. Thank you for joining us today.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.